I did get to spend some time, Darby and the folks in the audience with Janet last night, and I was really very excited about being able to just get in front of you all, let you know the health plan perspective and the priorities here in California for us, and then just really listen to you all and your questions really about innovating and advancing your priorities and the services that you guys have developed here in the local market. So with that, I'll just ask you, Darby, to to sort of moderate, and I can give you guys an introduction of what my experience is, a little bit more about my role, and a little bit more about the Centene California markets, if you want.
Yeah, that would be great. If you could introduce yourself and just kind of tell us, what you do and what you'd like to talk about today. And just for the attendees, I do have some slides that are kind of more here's some organizations, here's some definitions, like kind of informational slides that I will be sharing with you after, just so you can have that information. But we do want to take advantage of Mark being here and being able to like tell us about his work and answer your questions, everything. So we're going to try and stick with kind of a conversational Q&A like we've been doing. So Mark, I will and Janet, I was going to say I'll throw it to you, Mark. Janet has raised her hand, so we will throw it to Janet.
Yeah. Adding on to Darby, super excited to have Mark join us on a very, very short notice. Mark is fantastic. I feel like maybe some of you may have met him previously. If any of you went to Behavioral Health Tech Conference and attended the Medicaid sessions at BHT, Mark was phenomenal there. And so I'm really, really excited to have Mark join us today. After Mark provides his introduction, it's fantastic. Trust me. You're gonna be like, what? Anyway, he will definitely love to answer all of your questions. And I think what would be really awesome would be to feel comfortable in asking any questions that you have, any pressing questions that you have that is very specific to your companies. I think would be really, really great, for Mark as well, so that, he can answer your questions. And sometimes, like, some people may have the same questions. So please, 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 this is a safe space. Do not be afraid to ask any questions you have to Mark. And I just wanted to emphasize on that.
Thanks, Janet.
Yeah. So again, guys, I'm just after talking with Janet at length last night. It was just I was super excited for this opportunity, and as she pointed out, I was at the Behavioral Health Tech Conference. The leadership team there did a phenomenal job in putting that conference together. I got to present in a Q&A forum of just what new innovative groups really what does the health plan need from you all, and how do you influence and really deliver the services and make those connections with health plans. So a little bit about me. I started out as a registered nurse way back in the early 1990s. Worked as a critical care nurse and emergency room nurse for over 20 years. Then went off into nursing leadership and found my way back to a very small town here in California called Portola, California. It's up about an hour and a half, about an hour northwest of Tahoe in the Sierra Valley. And there's really a town of 2,000 members or individuals that live in the town that I'm in, and the county is like 25,000. So it's a very rural area. And as I took over first I was a director of nursing in the hospital, and then I went to the clinical outpatient setting in the clinics, and there was really a need because the nearest tertiary centers and specialty care is really an hour away, which doesn't seem like that's a whole lot, but especially in the winter months, the roads are closed, chains are required. It's often difficult to keep a year-round productive system going where members can get and patients can get care. And then not to mention, especially in the medical space, it's Reno's in Nevada, obviously, and Medicaid's a California payer. So the closest then city for them to go to is over 3 hours away through even more rural areas and more and more difficult terrain to travel through. So long story short, we realized that getting a neurologist, let's say, to come to my little community was just the chances were really non-existent. So I really got involved in really the telehealth movement, and I was doing some telehealth innovative things like remote patient monitoring and nurse advice line work that was really considered under the umbrella of telehealth, but that didn't wasn't really considered telehealth at that time, and things were way different. It was much harder to do things because you had to have video conferencing machines that would communicate only with between the two branded video conferencing units. It was very expensive. And sometimes they were bonding 4 telephone lines together for an ISDN line that was making 4 long distance calls. Anyways, evolving till now, I see this as a really golden hour, and I think COVID really had a huge impact on the just how we view telehealth. And we at the helpline, I was telling Janet last night, it's like we really discovered if we don't have a mobile telehealth solution for people to have immediate access for general medical services, we're so far behind our competitors that it's just not even doable. So I run a program now. We have over 2 million of our 3 million members have access to virtual care just in one program alone. We were doing, last I checked, over 10,000 visits a month. And then I also worked in other innovative projects like electronic consultations, which are primary care physician to specialist, asynchronous consultations. I've done things with school-based telehealth. And then other just clinical non-synchronous type programs that have offered value to our members and really ensuring that they have access and they're equipped with tools to make sure that that they're able to really, that we're able to achieve as close to the nirvana of health equity that we can, but also to make sure members are well armed and being able to have conversations with with their physicians. Not that they have to be armed, but they're very prepared to be able to navigate the health systems now. So we're as a managed care organization, especially on the Medicaid side, we have to be good stewards of the state's money and making sure that we're delivering the most cost effective, efficient care as possible. So we're always looking for innovators and relationships that make sense and provide value for, first of all, our members and the clinical outcomes, and then the health plan at large. So I'll stop there. It was a lot to throw at you, but I can't tell you that I went over the list of the folks that in the organizations that were going to be on the call last night. And I was just really delighted to see just the breadth and diversity of just the thought leadership that it took to get each of these projects off the ground. You guys, they seemed very well thought out, and the programs clearly are going to add value. So I wanted to applaud all of you guys on that, and just hear what questions you may have about how to get traction, how to influence, and really, for lack of a better word, sell the products that you guys have innovated and delivered on.
Can I jump in with a question?
Yeah, you bet.
Hi, Mark. I'm Grant, the founder and CEO here at Violet. Salome's a friend. I let her know about the shout out for going digital too. I'm a fan of the conference. One of the challenges we've had is, as we've been building relationships with lots of Medi-Cal plans specifically, we want to make sure that we're pricing appropriately so that as those relationships mature beyond the proof of concept or a pilot, there's no sticker shock. Essentially, we're working hand in hand to create value and capture value. Do you have any words of wisdom around how to structure pricing for pilots and part like proof of concept so that we can scale together?
That's a great question. And that is often, we get lots of pitches. I probably sit on probably half a dozen a month of folks that are approaching the health plan and really want to partner. And the words of wisdom that I can impart is that you really got to understand your market in developing that pitch. And it's even though one of the first questions you're going to be asked is, well, what is this going to cost us? You don't necessarily have to have the answer right then. You can have an exploratory conversation with the health plans, and why I say that is that California, as you probably know, is there's a lot of risk relationships and capitation in California. So it's really important to just understand what the priorities first are of the health plan and what their needs are, and then talk about relationships, because there's some products that we will offer and we'll take on the risk finances for, even though it's something that we generally expect out of the primary care groups in our PMP payments to them. So that often influences decisions. So it's really, what do you have to offer? How is it going to improve clinical outcomes and financial outcomes for the health plan in general? And then then that conversation comes in about where what members you're going to target. We generally, like every other health plan, the rates are a little bit more favorable on the commercial side, for those products and those offerings that we have. But just to make sure that you're very clear on which segments and lines of businesses that you're going to be, really putting the services out to, and that should help drive and get you to the finish line on what it costs.
Thank you so much.
Yeah, it's kind of it's a little bit of a nebulous answer. I realize that, but I think the pearl right there is that it's just the market is very complex in terms of risk relationships. So you've got to be able to consider that before you have that initial discussion. And it helps to have a health plan buddy, right? That you can, that is well versed in how the health plan is structured and the network is structured. So if you can connect with someone that really understands that, in that organization you're going to be pitching to, that it's probably the most effective, best way to really guide the discussion and be prepared.
So, hi, Mark, I have a question. Can folks hear me? I'm sorry, I don't know if my connection is okay. Great to meet you and great to have you on board. So my background's in the Medicaid space, Medicaid policy, Medi-Cal policy specifically, and coming into the digital health world from working with Medi-Cal managed care plans. I think one of the things that we struggle with here at Rocket Doctor is having plans say, hey, really love what you're doing in the virtual care space. Love that you've researched our plan, where our pain points are, looking at our data from DHCS, things of that sort. But who are you working with in terms of other plans? And I think there's this level of like needing that connection of who else we've been working with to be able to say, hey, we want to give you a shot in terms of a pilot. So curious if you have any feedback of like additional things that can really pull a plan to say, let's take a chance. Because again, like saying all of those things that you just described that would be helpful in those conversations with plans, I feel like gets us to, hey, we want to hear more. But then again, when we get to the question of who have you been working with, then there's like some hesitancy. So curious if you have any thoughts on that or helpful information.
Yeah, actually, thanks for the question. I'm glad you're here. That's a tough question, and it is a tough, phenomenon. So I hear the angst in your voice. I can tell you that, we're all, everybody that is around the health industry, or just humans in general, are just, we're risk adverse, right? So when it makes sense to get, to go with very well-established groups that we know have a history, but
Okay.
it just, then it's not always favorable, in that aspect to just innovative brand new companies. So
Mhm.
with that being said, I personally am willing to take some risk and just, and,
Mhm.
I think you hit the nail on the head with the word pilot,
Mhm.
because if if there's, if you minimize and mitigate risk by offering a product line, or a service to, a segment of the planned products, or population that, is not huge, and you have a very clear value proposition. I think that's the key piece, right? Is like, what are you guys doing better than the other guys, right? Um, and how even if you don't have historical data, if you
Mhm.
can, come to the health plan with a definite picture of, hey, look, we this is what we offer. This is the new novel, concepts, and this is what we're going to achieve for you. I think that helps pave the way a little bit for that risk assumption.
Thank you.
Yeah.
Yeah, we realize that, there's the innovators are, they're popping up all over the place. And I had a conversation with Janet last night, is that there's just, it's like this tsunami after COVID, happened, and people started to really adopt and understand telehealth. I think it just, all the thought leaders and the seeds were planted. Every time I go to a conference, I think we're right at the edge of the envelope of innovation. Then someone comes up with some crazy, wild idea that is just phenomenal. So, be optimistic, positive, and just really, be able to communicate clearly that value proposition.
All right. Thank you.
You bet.
Uh, Hello, Mark. My name is Ryan Young. I'm founder and CEO of Apollo Technologies. Thanks for coming to speak with us today. My question is, from a payer's perspective, either at a California Health and Wellness or other payers that are operating in California, kind of what are they doing in terms of again preparing for the Medicaid expansion with undocumented immigrants, and what are kind of what are you hearing, and what kind of like some of the insider conversations that are going on right now to in terms of concerns and challenges that they're anticipating?
Yeah, that's a great question, Ryan. Thanks for asking it. So we're very aware, and we're making strides in our preparation. We have been for some time. Because it's a kind of our guiding light, is making sure it's easy for members to choose us, and we're prepared to serve those individuals. It goes back to conversation again that I had with Janet last night about just health equity, and making sure that, especially in the undocumented space, that, we're facing and we're sensitive to the linguistic and cultural challenges, or not challenges, I should say, differences, right? That, these folks are going to bring to the table. But there's also, economic challenges rather, that, these the marginalized populations face all over the place. And I think it's really incumbent upon us to make sure that we're aware of that. We are providing culturally sensitive care, and the processes that we are developing and the services that we offer are aligned with that. Because it's one thing to offer a virtual care program, but if you can't serve the entire market equally, then we've got a problem. And I think we as an industry, not California Health Net specifically, but just we as leaders in the industry, really have to make sure that we keep that ball right in front of us. Because, I just, in my heart of hearts, I don't think industry wide we're doing enough to make sure that there's, equitable care.
So in terms of like economic challenges that patients face, like what are some of the things that insurers are doing now that you're like, oh wow, this is something that's really great, or something that maybe California Health and Wellness is doing to, or discussions that may have gone on about potential solutions to helping some of the more economic challenges that patients face in accessing care?
Another great question. So HealthNet here in California, we're serving our Medi-Cal population, and we're making sure that they, there's a whole slew of programs from doulas, the community health workers, to our members connection programs that are, can reach out and assist members in real time and do home visits. There's CalAIM initiatives going on. There's a whole slew of work that we're doing, with housing initiatives and substance abuse initiatives. There's just a ton of work that we're doing. But again, it's a challenge that to make sure that, from a language perspective and from a culturally sensitive perspective, that, we realize it's not one size fits all, right? That we have to have culturally sensitive, wherever it may be, whatever, nationality, culture, group, that these members identify with, that we're sensitive to their needs specifically.
Quick question on that. I'm loving this discussion. How do you measure success in that area? Like, how do you know how well Medi-Cal is doing, or, how that's improving or not? Like, how are we tracking that?
Darby, that's such a great question. And, I have a boss that I really admire. And that's the first question she has is how are you going to measure success? How do you know you're successful? So I think it's, that the perspective that I have, and I think the health plan has as well, is that that's multidimensional, right? It's not, you just can't look at, utilization numbers and say, hey, we plugged in X amount of members into services last month. You've got to really look at the dynamics across, multiple dimensions in terms of, are we reaching, does the data show that we're reaching, membership and that are representative of all of the groups that we've identified in terms of, cultural, linguistic, ethnicity, all of that, and it's a true representation of the members that we have and we're covering here in California. And then I think one of the really most important points to me is does it matter? If I got a member on the phone today and I asked that member, did this matter to you? How did this help you? That resonates, and they're clearly able to see the connection between the program that we're offering and assistance and how that's affecting their health and improving their daily lives. And I could go into a whole bunch of, I mean, we could have a whole hour discussion on that alone. I mean, there's HEDIS measures, there's CAPS, there's all kinds of different, dimensions in terms of quality of care that we measure as well. So I think when you look at that holistically, I think that's the key.
Yeah.
CAP stands for what again?
Sorry?
Does anybody on the call know?
Capitation, or is there something else?
No, it's a survey that goes out to members on how they're rating their health systems, healthcare.
Okay.
Yeah.
Okay.
Sorry.
Yeah, no, this is a super important, I think we're all industry-wide more aware of, cultural competency being super important and lived experience being really important. So I think we're all trying to figure out how to measure success better, and I just find that really interesting. So thank you. But we do have other hands. I think I saw Scott go up first. I hope I'm not skipping anybody, but let's go with that.
Thanks, Mark. My name's Scott. I'm a project manager with Activate. And so I think the question I had for you is, when we were kind of dealing with the populations we're targeting, kind of these rural and underserved groups, we've learned that there's a pretty high technology literacy gap. Like, we're kind of providing these tools, and some of them, they haven't even had a smartphone before. And so I'd love to get your thoughts on, what that balance is for the service. Is it something that kind of needs to be baked in for kind of the technical, the tech support angle, or are you seeing groups that are kind of finding innovative ways to kind of bring in maybe third parties? And so I'm just kind of curious on that part.
Yeah, so I'm gonna answer part of this, and then Janet, I'm going to ask if you have, any comments as well from a tech equity perspective. As this whole phenomenon of telehealth is, well, first of all, Scott, I'm glad you're here, and I'm really glad you asked that question because it's really very important to me. We've been following very closely. So what I realize, even expanding beyond the linguistic differences and being able to address those within telehealth environments, there's also just the basic, if I hand you a smartphone, can you connect with a program, right? And so I look at it across a couple different dimensions. Is, are we driving our members insane by just saying, here's an app for this, here's an app for that, and here's something else you have to download, and here you're going to get text for this, and there's no ecosystem, right? So that's one of the things that I've been, really looking at is how do we build a cohesive, aligned ecosystem with all the programs that we're running to make it simple and easy for members to use. And then secondly, just there even before that even starts is if I hand you a smartphone and say, hey, we got this new nifty app you can download and all this stuff's going to be available, to you. Do you have the resources to do that? Do you have the knowledge base to do that? Do you have the data, requirements on your phone to manage that? So we have a great thought leader in our organization, that's our chief health equity officer, who's done a lot of work in the tech equity space, and it remains a big, it remains a significant challenge, right? Because everybody comes at different levels. Everybody has different resources and adequacy of resources at their, at their disposal. And then there's different environments that they have to live within. There's, Android and iPhone, and it's really been a challenge that I think we need to spend more time on and really address that. Again, it's an industry problem. Make sure that if we start and we offer these nifty programs, we're not, it isn't a pipe dream because, half the people don't know how to use it or don't have adequate resources to use it. So it remains a challenge for us that we're very interested in. And Janet, I don't know if you had any additional comments on that one.
Not really. I mean, Scott, could you repeat your question one more time?
Yeah, so this kind of calls back to some experiences we've had ourselves, and kind of like we did do co-design with ours, and so we went with patients, and we were kind of surprised even with that on some of their knowledge. We kind of asked them, did the pitch, and asked, what do you think? And we had a hand get raised, and it's like, yeah, what is a link? And so we kind of realized that there's a lot of people kind of need that foundational on ramp just to be able to participate in it too. It's not just like we can meet that health need, but there's also a technology need. And so I think my question really was about for these solutions, like what are people doing? Is it kind of a third party that they're finding that there's just going to be tech support for it? Does it need to be baked in and kind of thought through? Like we need to have people on staff specifically to help with that component.
It's a good question. From what I've seen so far from a investor CHCF perspective is that most companies have people in-house to kind of assist with that, because a lot of the conversations that I've come across with our internal program teams as well as other folks in the space has been around like who's on your team to kind of support those tools, and how are you connecting with other players in the space, whether it be from the community side, whether it be if you are talking to leaders, not just on the health plan side, but maybe in the clinic side, to kind of drive that forward. So I think it's really just about kind of talking to the leaders in the space and kind of developing that community, and also having folks in house as well to kind of drive that forward. Because a big question that is always asked, especially in our program teams at CHCF, is that if there's this tech solution that's developed around that, what's kind of the QA behind it? And so hopefully that answers your question. But I think what Mark said was also very awesome too.
It did. Thanks.
Awesome. Cool. I think who's next? QK? Yeah?
Yes.
Awesome.
Hi, thank you so much for that amazing presentation. I'm Kike again, and founder CEO of Wellness Swiss. It's a digital health platform for shared medical visits. So, Mark, we've done a little bit of research, not a little, a lot actually, on shared visits and how CMS addresses it. Do you have any insights as to what policies are in place? Because so far as we know, there aren't specific policies from centers from CMS, and we've been looking at how can we partner to see how we can scale it, amongst safety net organizations. And so, what thoughts and insights do you have for us in getting started with a partnership to help guide policy and how we build our solution to be in compliance with what's expected from the payer side of things?
Yeah, so Kike, can you, I'm not familiar with the shared visits. Can you expand on that a little bit?
So shared medical visits, it's a care delivery model specifically used to address workforce shortages, and it's pretty much where providers get to see more than one or two or five or 10 patients in one single appointment. And the way it's worked so far, as we know it, is that providers are able to bill for each individual in the appointment as if they saw them one on one. That way, they can maximize their time and clinical efficiencies, and also reduce documentation burden, because when they document for the group visit, and then they can apply personalized notes to individuals. So what we found is that a lot of health systems are beginning to do this. Cleveland Clinic, we've been in touch with them and talked with them. They've done over 250,000 encounters using shared medical visits, and it helped during COVID as well for organizations like Kaiser, which they had a lot of mental health populations needing help, and they couldn't get enough providers to offer services. So we built a platform specific for shared visits where doctors can use our platform for the documentation and scheduling of groups of people at once. So we've read a lot from the internet and different research papers on how these organizations have handled it. And so far, CMS has no specific policy. The American Family Medicine Association did reach out to CMS, from what I understand, and the response back was that as long as patients sign a waiver to say they allow their doctors to observe them in the presence of other patients, nothing stops them from billing regular A&M codes that they use during individual visits, ranging from 99212 down to 99215. So our thoughts are in the future, when this becomes a big deal, because we're seeing this is one of the best ways to really solve the workforce shortage issues, then policies will begin to emerge on that. But I hope that explains it.
Yeah, no, that was a great summary. Okay, I'd love to talk to you offline about this. I can, just for the edification of the group, I can give you some thoughts here. So sometimes it's a game of inches, like my Detroit Lions this weekend, versus huge strides. Electronic consultations in the state was an example. We're still meeting. I met with the regulators this week even to talk about just what the next steps are. So sometimes it takes time to evolve and for folks to get their arms wrapped around concepts like that. So, but with that being said, as a business innovator, you want to move things, right? Because you got to have money coming in the doors at some point. What I can say is that although this is the first I've heard of this, as a formal way of seeing patients, we're always being approached with items like this, or projects like this, that are innovative. No one's ever seen it, done it, and having a health plan partner is sometimes really helps move the needle a lot quicker. And then there's also we've got a core set of services that we're obligated to provide members as part of our contract with the state, but there's opportunities to innovate and offer services above and beyond those core set of services. So sometimes these are, projects are things that we would look at, again, in pilot, type environments where you may look at areas that are just, Fresno is a perfect example right now. Is they're having a surge in activity, around the respiratory viruses and people getting hospitalized and things like that, where it may be an environment where there's a very short supply of, of providers, even though that there's a defined continuum of, or life cycle to what's happening now. It might provide a test bed environment, to really consider a project like that, and to see if it's something that, is really, something that we would want to hardwire going forward.
Absolutely. I definitely would love to connect with you offline.
Yeah. So I'll follow up with Janet and see if I can get your email, and see, or Darby, and see if we can get your email, and I'll connect with you.
Janet
Absolutely.
definitely
Thank you.
can. Yeah, me too, but I know y'all are tight, so that would be great. Thank you for that really interesting shared visits idea. I've heard of that, but I didn't know much about it. That was informative. Shall we move on to Sana? Sana?
Hi. Oh wait, hold on. Let me cancel
Oh,
my
weird.
other meeting there. So to take the echo out. Can you hear me now?
Yeah.
Can you hear me? Okay,
Fine.
perfect. Also I was the one who asked the meeting about the TriNet and the Indian Health Services, but I was logged in on a different computer, so it had a different name. Yeah. So I had a question around the opinion about the best business models that he's seen that have worked in for the health net system. So someone else asked about pricing, and he said, it really depends on the system and knowing the system. But for doing pilots and building a business model, what kind of business models have they seen work and are scalable to start the pilot and then grow into integration with the hospital system or the health net system?
Sana, I'm glad you're here today. That's a challenging question, because there's so many variables to that, right? Some of the deals that we've entered in, relationships that we've entered, and have a per member per month base to it. If we see exceptional value, sometimes we'll seed. The project, or the effort, by providing some administrative front loading. It's just there's so many different variables. I've seen sometimes it's case based, sometimes it's that really makes sense, sometimes it's CPT based. What I can tell you is that all the health plans, that are Medi-Cal managed care plans, have what we call a rate development template, and services that are approved by CPT code by the department are find their way into this rate development template structure, and that's what we report on, and that's how we get our reimbursement rates at the health plan level figured. So we tend to limit the amount of reimbursement that goes out the door that isn't tied to CPT codes. But if there's exceptional value, or if it's just a service that is never going to be approved by Medi-Cal, or isn't in the foreseeable future, but we see value in it, we may monetize it and develop some kind of contractual reimbursement rate, based on what we think the service is worth and your time and effort.
Okay, so just to summarize that, most of the pilots that you do long term, you guys are looking for a rate development template that's tied to a CPT code. If that's not available, their special cases would be per month, per patient per month, or case base. That's at a high level.
Yeah, I mean, it goes beyond that, Sana. I mean, there's just so many. It just depends on what service you're offering. Sometimes it's like call centers and efforts to outreach to members and things like that. That we monetize on a anticipated FTE, perspective, and then whatever technology costs there are. There's so many variables.
Yeah.
If,
But the one,
if you,
the one that you've seen that usually the most popular or that typically is gravitated to by sites for long-term integration, or even looking at it from a pilot point, is CPT code related services that can be paid for through CPT codes.
yeah, I would say that that is true. I mean, if you're offering a service that has a medical CPT code, that's what we would prefer, is to negotiate rates around those CPT codes for the services that you're offering. But I don't remember specifically what your organization did.
Okay, no problem. I was just asking in general, what are the business models you saw that worked? And then
Mhm.
one quick follow-up question. So in some part of the workshop today, someone said, even if there's, let's say, not a code for payment, that the net health systems are used to being creative to find ways to pay for things, because it's difficult for them to get funding and they're hanging on. I wanted to know if you had any examples of what some of those creative ways that you have seen that people have paid for things that either don't have a CPT code or is on a per member per month basis, and how the site has come up with the funding to support those things that's outside of the CPT code.
Yeah, another great question. So, there's all kinds of things that we pay for and do that aren't, medical visit or the delivery of member facing medical care related. And we find ways of monetizing that, based on the services that are being offered and the value that we, are anticipating. So, but again, that's, we have, that's a great thing about managed care, right? Is that we get a set defined, amount of funding from the state on a per member per month basis. And then it's up to us as a health plan to, outside of the, within the confines of the guidelines of the contract with the state, that we're contractually obligated to offer these core services. There's all kinds of opportunities to innovate and offer services. And sometimes we work towards codes, like, in the instances of electronic consultations. We've worked for years with the state on, advancing that effort. But there's also, just, like app-based services that members have, that there's no way to tie that to any CPT code because it's not a doctor or a practitioner and a member.
Right.
But we find ways of monetizing that and getting it off the ground.
So the ways to monetize that is how? Is it coming straight out of the patient's pocket? Is it grant funding from the government? Is it additional Medicare innovation funding? What is the creative way for monetizing that?
Yeah, I mean, I think the simplest and probably most often utilized is the helpline just says, hey, look, we see forward, facing value in this. We think it's the right thing to do. We think we're going to get better clinical outcomes. So we just pay for it just out of our own funds.
Okay, thank you. And that's not like a special fund category. Like if we went to a plan, we should say, we would like you, we know there's no code for this. We want you to pay for this out of your blank budget.
Yeah, I would just say that, the buzzwords I would use is, we see this as a value add service that you can offer your members. And we realize that these don't represent, medical based, or behavioral health based services that can be quantified through CPT codes. But here's what our program does and how it adds value, and here's what, we think you can anticipate in savings. But this would, we understand this is a value add service.
Thank you so much.
Yeah, I hope that answers your question, Sana.
Yes, that was helpful. Thank you.
I think that is probably the question that I have gotten, and heard more than any other throughout the years of the challenge is, okay, but how do we reimburse this? What's the code we use? What do we do if there's not a code? I think we could probably do like a whole day like on just that. So I'm glad you brought that up. but I think we're coming up on about 10 more minutes in our session. So we have 2 more hands up. We have Ashley and then Catherine. So let's see what Ashley has to say.
Okay. Hi again. So a lot has happened in California. Man, what a year, right? With the reprocurement of plans, you
Yeah.
have increased rates for now really to incentivize more primary care providers and other folks in that space for Medi-Cal. Cal-AIM is happening. You have this new population of undocumented residents across all ages, right, that are eligible for Medi-Cal. I guess my question to you, and you can answer it specifically for HealthNet or just in general for Medi-Cal managed care plans, local and commercial, like, what do you need right now? What do you need? Where, like, what is your focus really in this new changing landscape of California? Like, what do you need to manage these new populations, current populations, new or current waiver? Like, just would love to hear some thoughts on how the technology aspect could be a supportive tool to those needs. But yeah.
Yeah, Ashley, you asked the hard questions. I love it. But yeah, thanks for that question. So, I think that's a very broad question, and it really depends on who you ask, right? Because we've got so many different functional areas of the health system, health plan, that you could get asked 15 different people and get 15 different answers, right? But I think at the very top level, I think it's, we want to make sure that we're prepared from a provider adequacy perspective, and to make sure that there's enough providers. And I think my day-to-day work really is driven around, I know it sounds cheesy, but it's like you're handing us a $50 million bill, and we've got 50 cents in our pocket, and we're trying to figure out how to pay that bill, right? Because there's just so many, there's so many Californians and only a limited supply of doctors. So how do we build something that empowers and enables our members to be able to navigate health systems, reduce unnecessary visits, but provide access that is, for when it's truly needed, provided in a, so it's available right away within a timely period of time. So, members don't wind up waiting or becoming so confused, or it just becomes so onerous to get to a doctor that they don't do anything, and then they wind up in the ICU, right? So, and I think once that's out there, then it just kind of opens Pandora's box. So, again, going back to, are we taking care of people of color adequately? Are we taking care of linguistic needs adequately, cultural needs adequately, educational needs adequately? So it provides a lot of really exciting opportunities to innovate and problem solve. But at the end of the day, it really goes back to that equation. Are we delivering effective healthcare given the amount of practitioners that we have available? So hopefully that kind of it's a broad answer, Ashley.
Yeah,
I'm here in
it helps.
silence.
No, it helps. I appreciate it. And I know every plan, every leader is different, and especially what they're managing and what they're thinking of, like, what's on their, what's top of mind for them. So I appreciate your thoughts. Thank you.
Yeah, you bet, Ashley. Thank you for the question.
I think I'm next in the queue. Hi, Mark. This is
Go,
Kathy Kim.
Catherine.
Hi, this is Kathy Kim with the Activate program. What we have done is built a platform for care coordination that integrates data from commercially available remote patient monitoring devices, integrates that into dashboards for the clinic and the patient, and then brings that data into EHRs and for patients with diabetes and hypertension. So we are a technology platform, but we think and we've piloted this in 4 health centers in California and found demonstrated substantial improvements in hemoglobin A1C and blood pressure. But we think what was really important was addressing how you actually get it implemented in the health center and you fill all of the operational needs and the training needs and the patient adoption needs and digital literacy needs. It's sort of like filling in all of the operational capacity gaps that health centers have. So my question is, if we were to go to health plans and say, we're a platform, a technology platform, but we really help the health centers be like the best health centers that they can be for people with chronic illness, how would you state that value proposition for a health plan?
That's a great question, Kathy. Thanks. So I've had some exposure both as a registered nurse clinician on the remote patient monitoring and also just hearing from your peer competitors. I think remote patient monitoring is, it's a little bit of a challenge for health plans, but not necessarily for the health delivery system, right? Because health plans, it's hard, because we look at it as we're part of the puzzle, right? In these health centers, and we have influence, we can help, and we've designed and stood up programs that other of our competitor managed care plans have come on our shirt tails and said, well, yeah, we want our members to be part of this as well. How do we get, and we've already climbed Mount Everest of efforts of getting this thing deployed, getting it up and running, getting it available, for our members and for the physicians to use. But knowing in my heart of hearts that if you can include all members of all health plans and you're not leaving anybody behind, we get a win for our members, and that's what's the most important, for me. So I think coming at it from that perspective is important. We are often challenged because we hear from remote patient monitoring programs, and especially with the technology companies that say, hey, we can get these devices out to these members in less than 48 hours, and look at all the stuff it can do. And at the end of the day, it's like, do you have a clinician that's going to be responsible for monitoring the outcomes of the data, right? Which I'm sure you've heard these, heard this before. It sounds like when you're nodding your head. So that, I think it's, if I were your business guy on your end, what I would be saying, or what I would be trying to develop is, hey, we're going into these health centers. Our primary focus is make sure that nobody gets left behind. If you guys want to support this, just know that it's been very successful because everybody's been covered. And we were, have a clear picture of clinical monitoring and management. And then, just really leveraging those codes that are available for remote patient monitoring now to get reimbursement.
And is that something that a plan would then, support a pilot?
Yeah, I think so. I think if we, especially if you were driving, right, and you just you dragged us along for the ride, we could help influence and we could help support it financially through the CPT codes. But again, I would be prepared to just have a very clear picture of how it's working, how much utilization and uptake you're getting, how nobody's going to get left behind, and your clear plan of implementation and scaling.
Right. Thank you so much.
Yeah, you bet.
Thanks, Mark. Thanks, Kathy. Okay, y'all, we are running over on time, which I'm okay with if you are, but I don't know if Mark, if you have just a few more minutes to do one more question from James, or not, that is
Yes, go
open.
ahead.
All right, James, what you got in just a minute or so?
Okay, sorry about that. Hey, thank you so much. Just a quick question. You kind of talked about the provider, I guess the provider shortages, for lack of better words. In terms of any, I guess, newer innovative care delivery models, what have you seen that's been interesting there? Or is the provider shortage just something, you guys are just working through without expanding to new care models or new types of providers? And I should also say, sorry, I'm James Lott, founder and CEO of Scripted. We enable pharmacists to provide direct patient care at their local pharmacies.
Yeah, no, that's great, James. It's, and that's more important than ever now, right? And yeah, so I'm very supportive of just the concept and the work that you guys are doing. So the in the innovative space, I think electronic consultations are the things that we have put a lot of effort behind, where um, and it expands out to pharmacy too. So that might be something you want to consider as well. We're not using it for pharmacy here at the health plan, but I know that there's folks that are using it. But really looking at how do we build a better mousetrap? How do we get effective clinical resources out to providers to be able to manage members the most efficient way possible? And with electronic consultations, I think when you're asking about where have I seen innovation, I think that's been the biggest win for us. I think is because providers get counsel from specialists, and they don't really need to send folks out unnecessarily to specialist appointments. When they do need to send them out, they've already gotten a consult, digital consult, and they know what tests to order and what labs to do and things like that, what meds to start. So when they get in front of a specialist, they're very well prepared for that first visit. So that's helping declutter, the space. I think we still have a lot of, we still have, there's a lot of runway still in front of us in terms of, scaling and making sure that it is really present wherever, our members are. But I think that's certainly helped, and it's an innovative idea that I can share with you.
Yeah, so innovative tools essentially though, right? Is that what I'm hearing?
Yeah, just innovation tools, and how do you resource clinicians in the best way possible, making it easy so it's not a hassle and it doesn't create more work for them, to be able to care for these members more efficiently and more timely.
Awesome. Thank you for that question. So we are going to head out into a break. We're going to break for a little less than an hour at this point. We'll come back at what time is it? It's 3 p.m. where I am, 1 p.m. Pacific. So we'll be back at like 2 p.m. Pacific. 3 Mountain, 4 Central, 5 Eastern. We have one more question in the chat that I don't know that we'll have time to fully answer, but I don't know if there's a quick response to this. But knowing there's a lot of questions around pricing, are there resources we should read to understand how MCOs budget? Any links or Googles we can maybe send out? We can send out something out in the chat or something after.
Yeah, so Darby, I can just say quickly that, because we're, for profit, obviously, there's unrestricted funds. So, I don't want, because it seemed like folks had really thought that, there has to be some special, Medicare innovation budget, things like that. And it's not that prescribed. I mean, there's unrestricted funds that we use to seed projects, and we budget for throughout the year, and it's just again part of that value add budget sort of category. So I hope that helps.
Thank you. All right. Well, everyone, thank you so much. Mark, that was like so much information so quickly, and I just really appreciate you like taking everyone's questions and joining us on short notice. Really awesome.